Newika Clinical Conversation, and this is a session in which we task Dr. Honorable Dr. Chandrasekhar Prasad Singh, sir, the senior consultant from HCG Ranchi, and also Dr. Abhijit Das, who is from the HCG Kolkata, is a senior consultant clinical oncologist, and also Dr. Paulomi Basu, ma'am, who is a senior consultant medical oncology from NCRI Hospital, Kolkata. So we are going to start the first session with our respected Chandrasekhar sir. So handovering the session to Dr. Chandrasekhar sir. Good evening, sir.
Yeah, good evening, Sagnik.
Thank you.
Is my screen visible?
Yeah, sir. Very much visible and audible, both are, sir.
All right.
Yeah.
Yeah, so good evening, everyone. I would like to thank Bayer team for the opportunity. I'll be talking about what are the new options we have when it comes to treating metastatic hormone-sensitive prostate cancer. These are my disclosures. So this is the natural history of this disease, prostate cancer, and initially disease is patients can present to us with localized disease. They can present to
Hey.
us de novo. Yeah, am I audible?
Yeah, audible. Audible,
Yeah.
sir.
So patient can present to us with de novo metastatic disease, and ultimately it becomes hormone resistant or castration resistant. So once it becomes castration resistant, overall survival is not great, and despite having so much improvements in therapeutics, still overall survival improvement after doing everything is not very encouraging. Yeah, so we should not miss the opportunity, to delay castration resistance, and we should focus mainly when it becomes when it is hormone sensitive, and we try to delay the uh, patients or castration resistant setting, and that's how we can improve the outcome of patients having hormone sensitive prostate cancer. So this is the landmark trial, Stampede trial, where they compared, conventional treatment, androgen deprivation therapy versus addition of docetaxel, and you can see the survival curves were separated by far. So adding docetaxel to a particular subset of patients, initially high volume disease, benefited in terms of overall survival. Still, we can discuss about
I think some technical issues. Hello. Yeah, yes, visible, sir.
Am I audible?
Yeah, yeah, right now audible, sir. It was static actually for a few seconds. It is
Yeah,
audible.
some network
Yeah.
issue. Actually, there
Yeah,
is a
yeah,
power cut. Yeah.
yeah. It may be, maybe. No issue, sir. No issue. You can carry on, sir.
Yeah.
Yeah.
Yes. So, despite adding docetaxel, there is scope where we can do better, and that's where we will have discussion today. So coming to the role of radiotherapy, it has been shown that adding radiation to docetaxel in hormone sensitive setting doesn't benefit all. If particularly a patient has low volume metastatic disease, then it does not have much benefit in terms of addition of radiotherapy. But yes, if patient has metastatic sites less than 4 or low volume metastatic disease, then adding radiotherapy to localized disease has shown benefit in terms of overall survival benefit. So in hormone sensitive metastatic setting, adding radiation does not help all patients. And if patient has low volume metastatic disease, then it does help. So these are different, systemic therapy, systemic agents which are used. Uh, just a second, I'll turn on my webcam.
Sir, if any technical issues, you can continue, sir. No issue.
All right, all right.
Yeah. Yes, sir.
Yeah. So these are different, systemic agents which are used in treatment of hormone-sensitive prostate cancer. We have options of giving docetaxel. We have options of, adding different androgen receptor pathway inhibitors or anti-androgen agents, and all of them had shown significant overall survival. So now we have a lot of data, wealth of data supporting, concomitant therapies. So the next question comes, what we should choose. So we will do some cross trial comparisons as well as toxicity profiles of this drug, and mainly they are chosen based on toxicity profile. So if you see the data of chartered trial, then again there was improvement in overall survival in high volume patients. We know there was improvement in overall survival of nearly 13 to 17 months. To be precise, it was 16.8 months in patients having high volume disease when docetaxel was added over and above ADT. So median OS in patients having high volume disease with docetaxel plus ADT was 51.2 months versus 34.4 months in ADT alone, with a hazard ratio of 0.63. But if you see the hazard ratio in patients having low volume disease, it is 1.04. So there was not much benefit if patient had low volume disease. No, Latitude trial, it was done for abiraterone, and it has shown significant benefit, particularly in subset of patients having high risk disease. High risk meaning Gleason score of more than 8, high PSA. So if you see the survival curves after follow-up of nearly 52 months, these curves are getting separated beautifully, and abiraterone was the first agent to show that hormone treatment can be effective. However, it is important to understand that the treatment journey of the control arm was control arm when interpreting this data. So if you see the ADT plus placebo, then overall survival was 36.5 months. And when abiraterone was added to ADT plus placebo, then it was 53.3 months. So as compared to placebo, abiraterone addition to ADT improved overall survival by nearly 15-16 months. Now, this is again the challenge we face in our clinical practice, which dose of prednisolone to be given, 5 mg or 10 mg. So, standard is to give 10 mg, and sometimes where patient has poorly controlled hyperglycemia, 5 mg dose can be used, but again, there are high incidences of hypertension as well as hypokalemia due to mineralocorticoid excess. So a standard is to use 10 mg BD, and this is grade 3, grade 4 toxicity was were not much different when abiraterone was combined with prednisolone. Again, this is a novel anti-androgen therapy, apalutamide. It was compared with placebo over and above ADT. So it has shown improvement in progression-free survival as well as overall survival. If you see the hazard ratio, then it is well below 1. And if you see the subgroup analysis in patients having low volume disease, hazard ratio is 0.36, and in patients having high volume disease, hazard ratio is 0.53. So apalutamide addition to ADT has shown improvement in overall survival as well as progression free survival in patients having hormone sensitive prostate cancer. Now again, another agent, we have a lot of data for these drugs, and enzalutamide, we have data from Enjamite as well as Arches trial. So enzalutamide, when added to ADT, it has shown improvement in progression-free survival as well as overall survival, and hazard ratio is well below 1 in both the subgroup of patients. Similarly, patients having low volume disease, they were benefited more as compared to patients having high volume disease. Now we know that addition of docetaxel as well as these different agents, androgen receptor pathway inhibitor or anti-androgen agents, have shown benefit in patients having hormone sensitive prostate cancer. So can these agents be combined? We call it triplet therapy, and we have data now that addition of docetaxel to either abiraterone or darolutamide has shown improvement in survival of such patients. So PEACE 1 trial was done for abiraterone. It was a phase 3 trial, and patients having de novo metastatic disease were randomized into one is to there were four arms basically. So patients were randomized into across these four arms. So arm A contained standard of care, arm arm B was standard of care plus abiraterone plus prednisolone. Arm C was standard of care plus radiotherapy. Radiation was given to few subset of patients, and Arm D had standard of care plus abiraterone plus prednisolone plus radiotherapy. And inclusion criteria being less than 3 months of ADT prior to randomization, no prior cytotoxic chemotherapy or biological therapy, and patient were stratified as per their performance status, metastatic sites, whether patient had only bone metastasis or visceral metastasis or non-regional lymph nodes, and type of castration, that is orchidectomy versus surgical versus medical. So if you see the data of this trial, when patients having high volume disease were analyzed, then it has shown uh, improvement in median overall survival as well as progression-free survival, as well as there are other secondary endpoints like time to castration resistance, time to pain progression, PSA progression. So each and everything was improved in patients, particularly in patients having high volume disease. Patients having low volume disease, they were also benefited. The magnitude of benefit was less, and the hazard ratio was 0.83 in low volume disease. So this trial led to confirmation that in patients who had high volume disease at the time of randomization, you can improve outcome by adding abiraterone to docetaxel and ADT. Now again, this is another trial. This is global randomized double-blind phase 3 trial, placebo-controlled phase 3 trial, ARASENS trial, where patients having metastatic hormone-sensitive prostate cancer, having good performance status, and those patients who were candidate of ADT and docetaxel were stratified and randomized into 1:1 fashion to either docetaxel for 6 cycles plus darolutamide 600 mg twice daily along with ADT versus placebo plus ADT and docetaxel. So patients were stratified as per their extent of disease, whether they had only bone metastasis or visceral metastasis, and level of alkaline phosphatase. Primary endpoints being overall survival, and secondary endpoints being time to castration resistance, time to pain progression, symptomatic skeletal, event-free survival. So these endpoints are important when we treat any prostate cancer. So in this trial, 87% of patients received all 6 cycles of docetaxel, and adverse events were similar in both the arms. So in Peace One trial, we saw that patients having low volume disease, they were not benefited much. Mainly patients having high volume disease were benefited in terms of overall survival. But here in ARASENS, all comers were benefited, irrespective of the volume of disease. So if you analyze the data after 51 months of follow up, then nearly 63% of patients with who received darolutamide were surviving, versus 50% of patients who received placebo, and hazard ratio being 0.68 with significant p-value. So this benefit in terms of improvement in overall survival was seen in all comers. If you see the curves of high risk patient versus low risk patient, then hazard ratio is almost comparable. So darolutamide addition to ADT plus docetaxel benefited both the subgroup of patients who had either high risk disease or low risk disease. Now, these were key secondary endpoints: time to castration resistance, time to first subsequent other antineoplastic therapies, time to pain progression, and time to first skeletal related events. All the there were improvement in all the key secondary endpoints. So if you see the time to castration resistance, then 64% risk reduction with a hazard ratio of 0.36. Time to first subsequent anti-neuroplastic therapy, there was 61% risk reduction, and similarly, time to pain progression was improved. Time to skeletal related events were improved with addition of darolutamide. Now, again, this is another thing we look for when we treat any patients of prostate cancer: PSA kinetics. So, addition of darolutamide to ADT and docetaxel uh, led to faster reduction of PSA. You can see in this slide, patients having undetectable level of PSA was improved with addition of darolutamide. So nearly more than two-thirds of patients PSA reached below zero point 0.2 in all comers. And this reduction, or you can see that this reduction in PSA or time to PSA progression translated into overall survival benefit. Now, you can see that darolutamide triplet therapy achieved longer period of no disease progression, and also significant improvements in overall survival. PSA reduction was faster with addition of darolutamide, and time to PSA progression was delayed much as compared to placebo. So if you see the curve of time to PSA progression, that is becoming disease becoming castration resistant, then you can see the curve is almost flat after follow up of nearly 48 months. 91.7% of patients were having no PSA progression with addition of darolutamide over and above ADT plus docetaxel. So, what are the things we need to consider in our clinical practice, whether to choose for doublet and doublet versus triplet in the hormone sensitive setting? So, three, four things patient should be able to, tolerate and accept docetaxel. They should be fit enough, and you should evaluate the extent of disease, whether it is high volume disease or high risk disease, and what are the chances of hormone insensitive clones, what is the age of patient, and what is the life expectancy of that individuals. If it is a important parameter, then you have to hit hard and early, because once it becomes hormone resistant, then it is difficult to treat. And now we are exploring other areas as well. We have phase 3 data of adding PARP inhibitors in this setting as well. So now we are routinely doing mutation analysis in even in hormone sensitive prostate cancers. Earlier we used to do in only castration resistant setting, but now we have data from amplitude trial, and we are doing NGS in even in hormone sensitive prostate cancer. So if your patient is having high volume disease, if your patient is fit enough to tolerate the toxicities of docetaxel, then triplet therapy is the standard way to go, and this is what we are following routinely in our clinical practice. So with this, I would like to stop, and thank you all for your patient hearing.
Thank you, sir. Thank you, Chandrasekhar sir, for your nice presentation. And we are moving forward to the next session. And for next session, I'm going to invite uh, Dr. Abhijit Das sir from HCG Cancer Hospital, Kolkata. He is at as a senior consultant clinical oncologist there with rich experience. So we'll hand over the session to Dr. Abhijit Das sir. Good evening, sir, and welcome for this session.
Hi, good evening.
Good evening.
Uh,
Visible, audible and visible, sir.
okay,
Yes.
so just a minute, let me do a slideshow.
Yes.
Slides. Okay, so a very good evening to everybody. Uh, Today we have gathered to discuss a bit on metastatic hormone sensitive prostate cancer. And as my earlier speaker, I think, spoke on Arasen's trial. So basically, in the metastatic hormone sensitive prostate cancer, we tend to use darolutamide, docetaxel, and ADT component, specifically after the results of Arasen's trial. However, we also know that we have to be very cautious on the toxicity part, and we probably tend to use it in more fit patients. So there comes the next ARANOC trial, where they have actually omitted chemotherapy, docetaxel, from the arm of darolutamide and ADT, and they have compared it against the placebo and the ADT to check where the efficacy and the toxicity lies. So this is the mandatory disclosure. So as we all know that from the early 2000, a lot of trial has been designed because historically the ADT has been used in the metastatic hormone sensitive prostate cancer, but the results are dismal. So the initial charted and stampede has taught us that what there is a different PSA kinetics and a different outcome based on the amount of the disease, the volume of the disease, so low volume and the high volume. And then multiple trial has been placed, and we have seen the use of docetaxel, use of abiraterone, use of enzalutamide, the Titan trial, the introduction of the apalutamide. So it is to be noted that most of the trial they have shown an overall survival which is almost in the point in the hazard ratio being 0.66, 0.68, something like that. So no agent has a clear superiority over the other one. Then suddenly came this Arasen's and the subsequent ARANOC trial. They said that efficacy-wise and the toxicity-wise, if we add darolutamide, it has been a quite good outcome now we are having. But again, as I've told you that for the fit patient, triplet therapy, yes, but for the frail patients with a lot of high volume disease, sometimes the docetaxel may not be suitable, or maybe we need to stop that after some toxicity. So Arasen's, they showed beneficial efficacy and a very good safety profile that leads to its approval in 2023. But let's see what ARANOC data tells us. So it is a very nicely designed trial. First of all, the metastatic hormone sensitive prostate cancer they have taken.
So sorry to
Yes.
interrupt. You are not visible. Can you please on
Oh,
your
achha,
camera?
sorry.
Yeah. No issue, please. Thank you, sir.
Oh, am I visible?
Yeah, is it? Okay, sir. Thank you.
Thank you. So basically, they have included histologically and cytologically confirmed adenosis prostate. Interesting to know, they have included till ECOG 2. So PS 0, 1, and 2, everything has been included. They have included quite a few patients having visceral mets as well. Prior local therapy has been taken into account. So basically, both de novo and the recurrent patient both have been included in the trial. So they have done a 2:1 randomization with darolutamide 600 milligram BID and with ADT versus the placebo and the ADT. The primary endpoint being the radiological progression-free survival, and the secondary endpoints is overall survival, time to CRPC, time to initiation of subsequent anti-neoplastic therapy, the rates of undetectable PS, that is the kinetics. Very important to understand the time to pain progression. This is something has not been used in a lot of trials, and obviously the safety profile. And later on, they have uh, used 100% crossover to open label darolutamide, and selected endpoint was the overall survival and the safety profile. The median follow-up at the time of analysis was darolutamide group 25.3 months and the placebo group 25 months. Screen is not changing. No, okay. So if we go and see the demography, the median age was 70. So a lot of aged frail patients have been included in this trial, which is interesting to note. There is a significant nearly 30% in the both arm was Asians. It has a bearing because it has more generalizability in the modern world. The ECOG PS near 50% of them are ECOG PS 1 and 2. The Gleason score more than 8 was again almost 65 to 70% in both the arms. Metastasis, most of the patients are de novo, 70%, but there is a good chunk of patient where it's taken as a recurrent metastatic hormone sensitive PC also. Disease volume, again, in both arms, nearly 70% have been high disease volume. Around 12% in each arm, they have visceral mets. And prior local therapy, as they have taken recurrent patients, obviously the prior local therapy have been utilized and included in the trial. This is very important to see. Why I have told it's important to note that they have a significant Asian population representation, because earlier maybe it is a MCRPC trial where COU, abiraterone, or Vision trial where they have utilized lutetium, Embark also. They have not taken a lot of patients from these Asiatic regions, but in the Aranaut trial they have actually utilized China, India, and Taiwan, Australia, and the New Zealand as well. And it's a very good number of patients, almost 30% of the total population, whereas the Latin America has another 30%, and the rest of the Europe and the other world is 41%. So basically, it has a more generalism. So at the time of analysis, with that median of 25.3 months of follow-up, we can see the hazard ratio being 0.54. So there is a very good 46% death reduction in the darolutamide arm. If we see this forest plot, the first thing I want to notice is that overall population, the HR is almost 0.54. And we can see that is a very narrow confidence interval of 0.41 to 0.71. Again, if we see the age-wise subgroup, the 65 to 74, that age group, that commonest age group has HR ratio of almost 0.64, line of unity not reached. If we see the ECOG PS, it is both in the 0 or more than equals to 1. The results is quite same. And if we check, there is an Asian component there, though the confidence interval is 0.35 to 0.98, but there is a clear favorable darolutamide results. Visceral mets, obviously, if it is there, then probably the results is not that good because it is breaching the line of unity. And the disease volume wise, it is both favors darolutamide, both in high volume and the low volume. Though OS is too early to predict and it is showing 0.81, which is too good. So probably with the longer follow-up, it may come down, but definitely it is now at this point favoring darolutamide. The other time to metastatic CRPC or the PSA progression or utilization of the subsequent systemic therapy and the pain progression, if there is a clear winner is darolutamide. But since the OS is immature, so I will not comment on the OS. So as we can see, the time to MCRPC it is 0.40. There is 60% death reductions. And whereas the time to pain progression, again, it is better in the darolutamide arm. And this delays to time to pain progression is very high important because often we can see the patient faltering on the treatment because of this. So if we see the PSA kinetics at any moment in the darolutamide arm, the PSA being undetectable is more, it's almost found in the 60%, whereas placebo plus ADT is only hovering around 20%. Time to PSA progression hazard ratio is again 0.31. So there is a 69% improvement in time to PSA progression in the darolutamide arm. The PSA kinetics in both high volume and the low volume, we can see that clearly darolutamide excels compared to the placebo and the ADT. It is very important. It is actually in this arm, we can see that more amount of docetaxel in placebo and ADT arm utilized post subsequent life prolonging systemic therapy, which is around 28.8%, which is expected kind of. But from the data, we can see that subsequent utilization of systemic therapy is much more in the placebo arm. So darolutamide actually has a longer control. If we see the treatment emergent effects, it's actually less, and discontinuation of darolutamide is less compared to the placebo and ADT. Though I will like to check the entire data because against the placebo, it has been uh, experimented. But the safety profile in the ARA note, it is independent of PSA response and it has a favorable tolerability. So probably here also the darolutamide is the winner. In the adverse effect arm, it is actually better here. We can see that there is a slight increase in the cardiac arrhythmias and the coronary artery disorders, which is much less in the placebo and the ADT. But however, if we check the EAIR, the exposure adjusted incidence rate, that is nearly similar in both arms except these cardiac arrhythmias and the coronary artery disorders. Important to note that in case of fatigue, it is 5.7 in the placebo, whereas 3.2 in the darolutamide arm. So basically, fatigue is much less in the darolutamide part. And there is this uh, quality of life XP score where you can see that there is a delay of 5.1 months in the darolutamide arm. And that is because I think it is a meaningful delay of that pain progression and overall well-being because fatigue is less and time to pain progression is later on. And again, if this forest plot, if we can see that social or family well-being or the functional well-being is basically better in the darolutamide. There is some physical well-being, I think that is may related to fatigue and the bowel symptom that is a uh, bit worse compared to the other component. So by conclusion, we can see the darolutamide has a better safety profile with less amount of fatigue and treatment discontinuation. So it significantly has a improved radiological progression-free survival. All secondary endpoints, it unifiedly is shown a benefit across all points. There is a very deep PSA response, and it is the only AR inhibitor to demonstrate a meaningful delay in the pain progression. That what I have told that it has not been utilized in prior trial very much. There is a overall social, functional, and well-being. Urinary symptoms are better. So safety-wise, it is better. So we may think that if it is a fit patient, we may utilize the triplet therapy. But where the patient is not that fit, we can use darolutamide along with ADT. But obviously, the head-to-head trial, which is actually lacking so far, should be done with the other ARY or the abiraterone or enzalutamide, etc. But as of now, with this data, darolutamide without docetaxel with ADT, it should become an additional standard of care for metastatic hormone-sensitive prostate cancer. Thank you. Hello.
Thank you, sir. Thank you for your nice presentation. I hope that slide is almost completed. So thanks to Dr. Avijit Das sir for your nice presentation. of darolutamide without chemotherapy of Aranot evidence, and we are going to forward to the next session. Coming to our next speaker, Dr. Poulomi Basu ma'am, who is from an NCRI Senior Consultant Medical Oncology from NCRI Hospital, Kolkata, for our presentation on the management of MHCC with real cases. So, am I audible, ma'am?
Yes, yes,
Okay. Should I share, ma'am, slide?
yes, yes. Kindly share
Okay.
the slide from your
Yes,
end.
yes, sure, ma'am, sure. Just one minute. Is the screen visible, ma'am?
Yes, yes.
Okay, just one minute. Just one
So,
minute. 1 minute. Oh, I know it's just 1 minute. Ma'am, just 1 minute. Huh?
yeah.
Is it visible, ma'am?
Yes, visible.
Okay.
So now coming to a real world case, which is a non-metastatic CRPC. So we have already we know that yes, according to Aracin data and according to Aranode data, for metastatic hormone sensitive prostatic cancer, we have option of this darolutamide as either as a triplet regime or as a doublet regime, where they used, according to Aranode, they used darolutamide plus ADT. Now coming to a real world case, the patient is diagnosed of a non-metastatic CRPC. Next slide.
Yes.
So this is my disclaimer. Now coming to patient background. So it's a 73 years old gentleman, retired gentleman. Patient had a history of CABG, and the patient had a complaint of frequent micturition along with left-sided inguinal swelling for last 3 to 4 months. And at that time, one MRI prostate was done. Next slide. Yeah. Uh, MRI was done on October 2018, and it revealed there was a neoplastic mass, a prostate with the extra prostatic extension, and along with that, there was multiple enlarged pelvic as well as left inguinal lymph node. Day one PSA was 265 ng per DL. So biopsy was done, and it revealed Gleason score moderately. It was adenocarcinoma, and Gleason score was 4+3, 7. So it's a case of metastatic prostatic adeno-CA. So metastatic workup, one PSMA PET CT scan was done. There was no match. So due to old age, patient was 73 years, and patient already had a history of CABG, lots of medication. Patient was on lots of medication. So patient not willing for surgery or radiotherapy. So patient, we started only leuprolide from November 2018. So, and these were the PSA value. There was consecutive 3 rise of PSA. Next slide. So these are the list of medication, as I have already mentioned that this particular patient had a history of CVP. So clopidogrel, Nicoran, aspirin, these are the list of medication. Next slide. So there was a 3 consecutive PSA rise. Next slide. Yeah. One PSA was 0.72, then there was again rise from 0.72 to 1.71, and again there was a rise from 1.71 to 2.4. So we use PSA doubling time calculator to know the PSA doubling time. So PSA doubling time was 9.9 months. So there was consecutive 3 rise of PSA value. Next slide. So at that time, PSMA PET CT scan was done on June 2023. So the patient initially started on leuprolide since 2018, and then June 2023, there was consecutive 3 rise. PSMA PET CT revealed there was no MATES. Next slide. So it's a case of non-metastatic CRPC. Because the PSMA PET CT report, again, there was a prostatic mass with extra prostatic extension along with some a node. Next slide. So there was no distant mix. Next slide. So these were the PSA response. So as it's a case of non-metastatic CRPC. So at that time we have 3 options. We have darolutamide, we have apalutamide, and we have enzalutamide option. So among 3, we started darolutamide since September 2022, and this was the PSA response. Still, this particular patient is on darolutamide. Patient last PSA was done on April 2025. It was 0.28. So it's a PSA response. And kindly, the previous slide, we did a PSMA PET CT scan on December 2025, which revealed that there was a residual disease, but there was no MATES, and it's a partial response. Next slide. So these are the PSA value, which we usually do 3 monthly basis. August 2025, it was 0.27. October 2025, it was 0.28. And February 2026, it was 0.32. So it's a very good PSA control. Next slide. So this particular patient still on darolutamide from September 2022 to now 2026. Last PSA was done on March 2026. And this therapy is well tolerated with a very good PSA result, PSA control. So why we select this darolutamide? One is because of this particular patient is an old age patient. It was 73. Patient had a history of CABG. So we know among 3, this darolutamide has a better safety profile. As we know, that because of its unique structure, it has less brain penetration power. So less CNS side effect if we compare with enzalutamide or apalutamide. We know enzalutamide and apalutamide, there are some CNS side effect because it penetrates CNS barrier. And another advantage, because this particular patient we know have lots of list of medication, patient already have lots of comorbidity. So we know among these 3 drugs, apalutamide, darolutamide, and enzalutamide, this particular drug has least drug-to-drug interaction. So that's why we select this particular drug. And this patient also has a history of seizure. So as I have already mentioned that darolutamide has the least brain penetration power. So that's why we select this particular drug. And till now, the patient is on darolutamide with a very good PSA. So next slide. So now coming to conclusion, as a whole, we can say that darolutamide has a better safety profile with lesser drug-to-drug interaction. So it's a safest therapy in patients with a history of seizure or history of any CNS disorder, we can say. So according to Aramis trial, where they use this darolutamide along with ADT for non-metastatic CRPC patients, according to Aramis trial, we know that darolutamide have longer duration to progression in bony pain and least impact on quality of life, because we are talking about prostatic cancer patient where quality of life is very important. So as a whole, if this particular drug has a very good efficacy with least side effect. So with this, I think I conclude my talk. Next slide. Thank you.
Yeah, indeed. Fine. Thank you, ma'am. Thanks for your nice presentation of the patient was almost from last 2 years running on. And thanks to our previous speaker also, Dr. Chandrasekhar sir, Dr. Abhijit sir, and also follow me, ma'am, for this is for all of his the nice presentation on that way. So with this, if anyone has any kind of questions or any related question, then this is the forum. You can ask. So I think there is no such a questions we assume. So uh, can I go conclude the session?
Yes, I think.
Okay, yeah, I think that. Thank you. Thanks to our all speaker, and thanks for this coming to this new clinical conversation. Thanks to all.
Thank you.
Thank
Good
you.
night.
Good night. Good night.